You've probably heard that phrase before, maybe in a medical drama. The worst headache of your life. A sudden, explosive thunderclap headache. For any doctor or nurse, that phrase is a massive red flag. It's the starting gun for an all-out medical sprint.
You see, what follows that headache is this incredibly complex, minute-by-minute battle against a whole cascade of potentially devastating problems. We're going to walk you through the modern game plan that gives these teams a real fighting chance to win that race.
So what exactly is an ASH? Well, the easiest way to think about it is to imagine a tiny, weak blister on the wall of a blood vessel deep inside your brain. That's the aneurysm. When that blister bursts, blood suddenly gushes into the space surrounding the brain. And that's a huge problem, because that blood is toxic to brain tissue and it causes the pressure inside the skull to skyrocket.
Okay, so right out of the gate, the #1 absolute top priority is to prevent a second bleed. A rebleed is often way more catastrophic than the first one, so this fight begins the second that patient rolls through the doors of the emergency department.
In that initial whirlwind, the team is juggling like 4 things at once. First up, the ABCs: airway, breathing, circulation. You have to make sure the patient is stable. At the same time, they're working to get dangerously high blood pressure down, because that pressure puts a ton of stress on that damaged vessel. Then, if the patient is on any blood thinners, they have to reverse those immediately. And finally, they start a really important drug called nimodipine. We're going to come back to that one, because it's a huge player later in the game.
All right, once the patient is stabilized, for now, the next urgent step is to see what's actually going on inside their head. I mean, you can't fix what you can't see, right? So, how do they do that? How do you get a crystal clear look at the brain to confirm there's a bleed and find out where it's coming from, all while that clock is just ticking away?
Well, the go-to tool is a CT scan. It's fast, it's effective, but here's the catch. Its accuracy is completely tied to how quickly that patient got to the hospital.
If that scan happens within 6 hours of the thunderclap headache, modern CT scanners are incredibly good at seeing the blood. A clear scan inside this window is a very good sign.
And this is why getting help fast is so critical. After 6 hours, the body starts to, reabsorb the blood, making it much harder to spot on a standard CT. So a negative scan at this point doesn't give you the all clear. Doctors have to dig deeper, maybe with a more advanced scan that looks at the blood vessels, or even a lumbar puncture to check the spinal fluid for blood.
So imaging has confirmed the bleed and pinpointed that ruptured aneurysm. Now, the next stage of the race kicks into high gear, permanently fixing that leaking blister before it can rupture again. And the goal here is non-negotiable. Secure that aneurysm within 24 hours. Every single hour that goes by with that aneurysm unsecured is another hour the patient is at risk for a truly devastating rebleed.
Basically, there are 2 main ways to fix it. First, you've got endovascular coiling. This is the minimally invasive route. A surgeon threads a tiny tube, a catheter, up through an artery, usually in the wrist or groin, all the way into the brain. Then they carefully pack that aneurysm blister with tiny, soft platinum coils to block it off. The other option is microsurgical clipping. This is open brain surgery, where a neurosurgeon actually puts a tiny metal clamp on the neck of the aneurysm from the outside, sealing it shut.
So which one's better? Well, a huge landmark study called the ISAT trial gave us a pretty clear answer for a lot of patients. It found that for aneurysms that could be treated either way, coiling led to better functional recovery for patients a year down the road. It really was a game changer and shifted the way a lot of these are treated.
But here's a crucial point. Even after that aneurysm is successfully clipped or coiled, the patient is not out of the woods, not by a long shot. There's a second, more sneaky threat that's just starting to build.
And this threat is called delayed cerebral ischemia, or DCI. Basically, the blood that leaked out during the initial rupture really irritates the brain's arteries. In response, those arteries can start to clamp down and narrow. That's called vasospasm. And when they narrow, they can choke off blood flow to parts of the brain, causing a stroke, sometimes days after the patient seemed to be getting better.
This timeline just shows you how long the team has to stay vigilant. The risk of vasospasm doesn't even really start until about day 3 after the bleed. It hits its peak danger zone between days 7 and 10, and the medical team stays on super high alert for a full 3 weeks, just watching around the clock for any sign of trouble.
And hey, remember that drug they started way back in the ER? This is its moment to shine. That drug, nimodipine, is the only medication that has ever been proven to improve a patient's functional outcome after this whole nightmare. It's given like clockwork, every 4 hours for 21 days straight to protect the brain through that entire vasospasm danger window. Okay. I know that was a ton of information. So to wrap it all up, let's just distill everything down into 3 golden rules that really guide the modern playbook for treating a ruptured brain aneurysm.
Rule number 1 is all about speed. That aneurysm has to be fixed, either with coils or clips, inside that first critical 24-hour window. It's the most important thing you can do to prevent a second, often fatal bleed, period.
Rule number 2 is about consistency. That 21-day course of nimodipine isn't optional. It's absolutely essential. Again, it is the only therapy that science has proven helps patients recover better by fighting off the worst effects of that vasospasm.
And rule number 3 is all about being precise. The old way of thinking, this thing called Triple H therapy, was to proactively pump patients full of fluids to raise their blood pressure. But we now know that's actually not helpful and can even be harmful.
The modern way is to keep a normal fluid balance and only use medications to raise blood pressure if, and only if, a patient is showing clear symptoms of vasospasm, and only after the aneurysm is completely secured.